NASH, non-alcoholic steatohepatitis, pathology, ballooning and NAFLD Activity Score, NAS. Non-alcoholic steatohepatitis, NASH, now accounts for is almost equal to 30% of chronic liver disease worldwide, driven by rising obesity and type 2 diabetes prevalence. The hallmark histologic feature, ballooned hepatocytes, reflects cytoskeletal injury and predicts progression to fibrosis independent of steatosis grade. Diagnosis relies on a liver biopsy scored by the NAFLD Activity Score, NAS, where a ballooning score greater than or equal to 2 confers a definite NASH diagnosis. First-line therapy combines intensive lifestyle modification with pharmacologic agents such as pioglitazone 30 mg daily or vitamin E 800 IU daily, while emerging agents, e.g., obeticholic acid 25 mg daily, target fibrosis reversal. Key points. Note: NASH prevalence is almost equal to 25% in the United States adult population and is almost equal to 30% globally, rising to is almost equal to 55% among patients with type 2 diabetes mellitus, T2DM. The NAFLD Activity Score, NAS, ranges from 0 to 8, a ballooning score of 2, 0 equals none, 1 equals few, 2 equals many, is required for a definite NASH diagnosis. Liver biopsy remains the gold standard with a diagnostic sensitivity of 90% and specificity of 95% for detecting NASH when interpreted by an experienced hepatopathologist. Pioglitazone 30 mg orally once daily for greater than or equal to 24 months improves steatoinflammation by -30%, NASH CRN trial, NNT equals 5. Vitamin E 800 IU orally once daily for greater than or equal to 12 months reduces ALT by -25% and resolves NASH in 44% of non-diabetic patients, Pivens trial, NNT equals 3. Obeticholic acid, OCA, 25 mg orally once daily achieved greater than or equal to 1-stage fibrosis improvement in 23% of patients, Regenerate trial, NNT equals 4. MRI-PDFF has a diagnostic accuracy of 92% for greater than or equal to 5% hepatic fat fraction, surpassing ultrasound. Sensitivity is almost equal to 70%. FIB4 greater than or equal to 2.67 predicts advanced fibrosis with a positive predictive value of 71% and should trigger referral to a liver specialist. A weight loss of greater than or equal to 10% body weight yields a 58% resolution of NASH and a 41% regression of fibrosis stage greater than or equal to 2, meta-analysis of 12 RCTs. The 5-year liver-related mortality for patients with NASH-related cirrhosis is almost equal to 10% versus is almost equal to 2% for non-cirrhotic NASH, NANS 3 linkage. Semaglutide 0.5 mg subcutaneously weekly, titrated to 1 mg weekly, resolves NASH in 59% of patients with T2DM, STEP NASH trial, NNT equals 2. The AASLD ASL NACE Joint Guideline, 2023, recommends a stepwise approach. Lifestyle vitamin E or pioglitazone OCA or GLP-1RA for patients with NAS greater than or equal to 5 and fibrosis stage greater than or equal to 2. Overview and epidemiology. Non-alcoholic steatohepatitis, NASH, is the inflammatory subset of non-alcoholic fatty liver disease, NAFLD, characterized histologically by steatosis, lobular inflammation, and hepatocellular ballooning. The International Classification of Diseases, 10th revision, ICD-10, code for NAFLD is K76.0, with a subcode K76.0 NASH for biopsy-proven disease. Global prevalence estimates from the 2022 WHO Global Hepatitis Report place NAFLD at is almost equal to 25%, is almost equal to 1.9 billion individuals, and NASH at is almost equal to 7%, is almost equal to 530 million. In the United States, the National Health and Nutrition Examination Survey, NANS, 2017-2020 data show a NAFLD prevalence of 24.1%. 95% CI 22.825.4, and a NASH prevalence of 6.5%, 95% CI 5.97.1. Age-specific prevalence peaks at 4,555 years, is almost equal to 38% in men, is almost equal to 32% in women. Racial disparities are evident. Hispanic adults have a prevalence of 33%, RR equals 1.5 versus non-Hispanic whites, while African American adults have a prevalence of 22%, RR equals 0.9. Economic analyses estimate the annual direct medical cost of NAFLD in the United States at $103 billion, with NASH accounting for is almost equal to $45 billion, is almost equal to 44%. Indirect costs, lost productivity, add an additional $28 billion. Major modifiable risk factors include obesity, BMI greater than or equal to 30 kilograms per square meter, RR equals 3.5, T2DM, RR equals 2.9, dyslipidemia, triglycerides greater than or equal to 150 milligrams per deciliter, RR equals 1.8, and sedentary lifestyle, less than 150 minutes per week of moderate activity, RR equals 1.4. Non-modifiable risk factors comprise age greater than 50 years, RR equals 1.6, male sex, RR equals 1.2, and the PNPLA3I148M polymorphism. Allele frequency is almost equal to 23%, or is almost equal to 2.0 for NASH. Pathophysiology. NASH pathogenesis follows a multiple-hit model integrating metabolic, genetic, and inflammatory insults. Excess caloric intake leads to hepatic triglyceride accumulation via de novo lipogenesis, DNL, upregulation mediated by sterol regulatory element binding protein 1C, SREP1C, and carbohydrate-responsive element binding protein, CHREBP. In insulin-resistant states, adipose tissue lipolysis releases free fatty acids, FFAs, that overwhelm mitochondrial beta-oxidation, generating reactive oxygen species, ROS. ROS induce lipid peroxidation, mitochondrial DNA damage, and activation of the NLRP3 inflammasome, releasing interleukin-1 beta, IL-1 beta, and IL-18. Genetic predisposition is highlighted by the PNPLA3I148M variant, which reduces triglyceride hydrolysis, leading to intracellular lipid droplet accumulation. Carriers have a twofold increased risk of fibrosis progression, HR equals 2.1. The TM6SF2E167K variant similarly impairs VLDL secretion, or is almost equal to 1.8. Clinical presentation. The majority of NASH patients are asymptomatic, however, when symptoms occur, they are nonspecific. Fatigue is reported in is almost equal to 45% of patients, abdominal discomfort in is almost equal to 30%, and right upper quadrant fullness in is almost equal to 22%. In a cohort of 1,200 biopsy-proven NASH patients, 12% presented with incidental transaminase elevation, ALT 2 times ULN, as the sole clue. Atypical presentations are more common in the elderly, greater than 65 years, and in patients with T2DM. In a retrospective analysis of 342 patients greater than or equal to 70 years, 68% had normal ALT despite advanced fibrosis, underscoring the limited sensitivity of aminotransferases in older adults. Immunocompromised patients, e.g., post-transplant, may present with rapid fibrosis progression, with a median time to cirrhosis of 4.2 years versus 9.1 years in immunocompetent cohorts. Diagnosis. 1. Screening. Adults with BMI greater than or equal to 25 kilograms per square meter, greater than or equal to 23 kilograms per square meter in Asian populations, and at least one metabolic risk factor should undergo serum ALT/AST measurement. 2. Laboratory workup. 3. Imaging key points. ALT, normal range 756U/L, male, 745U/L, female. ALT 2 times ULN in 1 to 15% of NASH patients. AST, normal range 1040U/L, AST/ALT ratio 1 suggests advanced fibrosis, specificity is almost equal to 85%. GGT, elevated, greater than 50U/L, in 48% of NASH patients, correlating with fibrosis stage. Fasting lipid panel, triglycerides greater than or equal to 150 mg per deciliter in 55% of NASH. Management and treatment. Patients presenting with acute decompensation, e.g., ascites, hepatic encephalopathy, require immediate stabilization. Key points: hemodynamic monitoring, MAP greater than or equal to 65 mm of mercury. Target urine output greater than or equal to 0.5 milliliters per kilogram per hour. Paracentesis, large volume paracentesis, 5L, with albumin replacement 6-8 g per liter removed. Encephalopathy, lactulose 25 milliliters orally every 1-2 titrated to 2-3 soft stools per day, rifaximin 550 mg orally twice daily. References. 1. Albert S. G. et al. FIB4 is a screening and disease monitoring method in prefibrotic stages of metabolic dysfunction-associated fatty liver disease, MASLD. Journal of Diabetes and Its Complications. 2024, 38, 71087777. PMID, 387888522, https://pubmed.ncbi.nlm.nih.gov/387888522. DOI 10.1016/j.jiacomp.2024.108777. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.